make it here today. I'm a data analyst. I work for the Health Innovation Network in South London. So just a bit about the Health Innovation Networks, in case you haven't heard of them. So there are 15 networks across England. Each region in England has a network, and we bring together people in the innovation space, so universities, NHS trusts, councils, private sector innovators, care homes, the whole range of people to try and innovate. Our team specifically is an insights team, so we look at working with innovators to understand whether innovations are achieving the outcomes that people hope that they will. So the background to this project is that it's been well known for a long time that people with serious mental illness, there's a lower proportion of people that take up physical health checks than amongst people, amongst the general population. People with serious mental illness also have worse physical health outcomes, so having a physical health check can be really useful for people with serious mental illness. It's actually one of the +5 in the core 20+5 policy. So there's a real push to ensure that people with serious mental illness get physical health checks, and that's being done largely through QOF incentives to GP practices, but really, and having a target, but that more needs to be done around this. At the time of doing this project, there was a 60% target to have 60% of people on serious mental illness QOF registers to complete all 6 physical health checks. And since then, that has actually been raised to 70%. For those of you that don't know much about the physical health checks, it's a range of 6 tests. So that's taking measures of BMI, blood pressure, cholesterol, blood glucose, and also asking questions about alcohol use and smoking. So to complete a check, a patient would have to have all 6 of those things done. It's often the case that people might have their blood pressure done at an appointment for something, but they're not also asked about their alcohol use, for example. So with this in mind, we were asked by a group called the Cavendish Square Group. So they're the chief execs of the 9 mental health trusts that work in London, if we could do a bit of work understanding more about the serious mental illness population, and particularly those groups that are not having their physical health checks. So we first started with one mental health trust, so that was South London and Maudsley, which is on our patch in South London. The reason we worked with them initially is because we wanted to see what the availability of data was, and we knew they had really good data. But probably more importantly for us, we've got really good access to their data because we're part of the same group of trusts. So we knew we wouldn't have to overcome too many IG barriers. So we started off by working closely with them and doing some analysis of their data. And what it showed was the methodology we used was a really, really simple one. It wasn't very advanced statistically, but we took the data, we asked for data on age, ethnicity, gender, index of multiple deprivation decile, and serious mental illness diagnosis. And we then looked at those as subgroups and subgroups within subgroups. So within age, we would look at gender, and within age, we would look at IMD decile, etc. So we ended up with hundreds of subgroups. To decide actually which groups were not going for their checks, if a group was had more than 50 patients in it, and it was more than 5% of that group above the average for the whole data set, we were saying actually we're saying that group are disproportionately not having their checks. we used this approach, and it was my colleague actually did this piece of work, but we used this approach, I understand, because doing statistical testing was throwing up so much that the messages were actually getting a bit lost, and we wanted to be able to control the cut-off point so we could really target certain groups that weren't having their checks. It's hard. The data we were using was from mental health trusts. I think it's really important to mention that most people with serious mental illness are still looked after in the community by their GPs. And, there's a big barrier because this data isn't integrated. So without that integration, and by just looking at the mental health trust data, we're only understanding a small bit of that picture, and that's a really strong limitation to this work. And I'll get to recommendations in a bit, but we're now looking to really try and integrate that data because this is a really big example of where it's just not working. We just don't know enough. So in terms of the findings for our first trust, South London and Maudsley, so there was a patient cohort of 5,476 patients that were known to the trust that had a diagnosis of a serious mental illness. 28% of patients had received all 6 of their checks in the past year, and there was also 17% that had received none. We found that there was little variation when we just looked at ethnicity and sex on their own. And then we looked at which are the groups that the trust needs to focus on. So looking at the subgroup analysis. So we actually found that patients in the least deprived deciles, so that's deciles 7 to 10, and also those in the least deprived deciles that were female or white were more likely to have missed checks. Those diagnosed with bipolar disorder were more likely to miss checks. And whilst female patients as a gender group were not more likely to miss checks, when you combine that with those aged over 65, those that were white and those that were living in the more affluent areas, all with bipolar disorder, we were finding that there was a pattern around female patients when looking at those specific subgroups within the female population. So having done that analysis, we went back to SLAM and we went back to our commissioners at the Cavendish Square Group, and they asked us to proceed to try and get data for the rest of the 8 trusts across London. The idea being that we wanted to pull all that data together and get a picture across London, but we did also give each trust their own separate report so that they could see what their individual focus would be as well. I'm just going to go over the London-wide because I'm sure no one wants to hear 9 different reports, but we are hoping to publish them in the near future if anyone's interested. So we used the same methodology. We went out to each of the 9 trusts, including SLAM, to get their data. And we managed to get data back from all of them. However, there were some data quality issues around 2 of the trusts, so we weren't able to include them in the analysis in the end. So all of the data sets were combined into a single data set. It was a little bit tricky because some trusts decided to provide us with aggregate data and some nice patient-level data, so that was a lot of fun wrangling. And we had a reporting period of 2023. So based on the 7 trusts that submitted data, this chart is actually the number of checks missed. So 30% of people had all of their checks, and 34% had missed all 6 checks. And when we looked at which checks people were having, you can see from the second graph that it's those cholesterol and blood glucose checks were most likely to be missed, and we know that they're more problematic. It's much easier to ask someone, do you smoke, than it is to take a blood test and get the results and look at that. And then when looking at subgroup analysis, there was no difference when looking at just gender. In terms of age, those aged 65 plus were more likely to have missed checks around their BMI and blood pressure. And patients aged over 75 were more likely to have missed all checks. Asian patients was a group that were most likely to have missed all checks. And we found no differences when looking at deprivation deciles. And we also found that those with affective disorders were most likely to have missed all of their checks. And then we looked at the subgroup analysis, and I won't go through all of this, but this table highlights, so the bit in grey can be ignored because it's, we've got age and ethnicity twice within that grid, so it's just, there's no point doing that. But this highlights some of the subgroups, like people with bipolar disorder that are in the top 6 deciles were more likely to have missed checks, for example. So yeah, I won't go through all of that, but there were some very clear messages coming out of this analysis. So to summarise what we found at a London level, we really, in essence, those aged 65 and over were more likely to have missed their checks than younger patients. As was the case with Asian patients, those from Asian backgrounds were more likely to have missed their checks. And both white and Asian patients were more likely to have missed checks when they were also female, over 65. Or in the more deprived areas, deciles 1 to 4. And patients diagnosed with mood and affective disorders were also more likely to miss their checks, except people in the 75 plus age group. I guess the next bit is the so what. So, we've done this analysis. What is anyone going to do with it? Why does it matter? So we sat down, we convened a network of physical health leads for each of the 9 mental health trusts. We presented our findings and we did a bit of a brainstorm about what can we actually do about this. And unsurprisingly, the top recommendation that came out of that was the need to really push the integration of primary care data and mental health data to really understand the full picture. So the big action is to get some of the senior leaders in the trusts to speak to some of the senior leaders in the ICBs to start getting that moving in a serious way. Even if the systems can't integrate, there must be a way of integrating the data because we just don't know enough if we don't. But beyond that, there are ways of proactively focusing on some of these groups. There was discussions about some of the measures that happened during COVID to reach out to community and faith groups. There was some success around that with the COVID vaccine. There was talk about maybe trying to try that approach, particularly amongst Asian populations. And equally, some of the older groups to really get older adult community mental health teams involved in delivering some of these checks. That wasn't something that was happening routinely at the moment. And the other big barrier, I spoke earlier about how the checks that are most likely to be missed involve a blood test, but really looking at the accessibility of blood testing, but also looking at the role of point of care testing to try and get some of these tests done without having to go through the formal process of a blood test. And I think, I've this is my second project working in this space. I think when you look at the data, the thing you really miss, and it's much harder to measure, but what's actually happening once people have their check done. We all know that people with serious mental illness have worse physical outcomes, but it's not enough to do a check. We really need to start moving the dialogue and focusing on collecting good data on what interventions people are offered, whether they go through with those interventions, how much are these checks actually picking up on health conditions and leading to treatment. And it is a much harder thing to crack, but unless we start looking at that, we're not actually changing people's physical health. I'm going to leave that there and go to questions. Thanks.
Thank you, Polly. That was really interesting. It was a really lovely end to the Beckbury Day. So thank you very much. I'd just like to open the room now for any questions that you may have for Polly. Bianca, I'm so sorry. You're just having to run up and down at the moment. It's
You okay? Oh, there you go. Yes, I'm Sean Rowe. I come from NICE. I had a couple of questions. So the first one is, how did you define the SMI population? So did you copy like the business rules from the QOF register and then convert that into the trust? So like from the READ or SNOMED codes to the ICD codes? Yeah,
that's exactly it. So it was using the QOF definition. Yeah.
Okay, cool. And then the second one was, did you think, maybe not for this project, but for a future one, about maybe amending the health checks? Because I wonder if perhaps people with SMI might be more likely to have substance abuse issues. So maybe the pushback from the trust might be, we'll more concentrate on that rather than some of these other checks. I wonder if that's like something you could do in the future.
As far as I know, that wasn't considered, but that's an interesting point. There is some discussion about generally about broadening the checks. I don't think it was along the lines of substance misuse, but it does feel like a bit of a missed opportunity in a number of ways. I think we can take that back actually, and we've got a really engaged group now that want to do this. It's a lot of it has been dictated by this kind of QOF target, unfortunately, but there's a lot of people that want it to go further, so I don't see why it couldn't. That's a great point.
Thank you. So at least from the first trust that you looked at, the numbers were not that big. Mm-hmm. How did you handle the fact that in some of the subgroups the numbers of people might be quite small?
So in terms of our methodology, we were only flagging subgroups that had a minimum of 50 patients within them. I think we acknowledged that you are missing stuff at that level, but we were finding too much stuff was coming out as significant when we were kind of going too low and looking at too broad a difference percentage-wise. So the methodology is really simple, but I think the minimum of 50 in a subgroup was partly so that things wouldn't be swayed by really small numbers. You know, if you've got 10 people in a subgroup and 3 people haven't had a check, it doesn't tell you an awful lot about it at a population health level. But equally, we want them to target groups where there are a significant number of people to actually do something. So that's how we treated the data.
Hi, Hazel Kirkland from Nottinghamshire Healthcare. So I work in a mental health trust. Really interesting talk and really important work. I just wondered, do you know how the trust got the data? Did they use structured data or did they pull it out of the patient notes?
So they it was a little bit different for each trust, but essentially we designed a data spec, a very clear data spec and a data template, which in some case got ignored. and we're happy to share all of this with anyone if they want it. And we asked them to go away and pull the data off from their EPRs, essentially. It is a bit difficult because, like, we know that things get recorded in different places. It's not like on a GP record where you've got a really clear space to put these checks, but you know, your blood pressure could be taken at any point and could be recorded in notes. So we did have like SLAM that we worked with initially use a lot of natural language processing to really scrape that data from throughout their EPRs, but undoubtedly they don't all have that same system, so which is a problem in itself. When we met with the physical health leads, we actually had quite a long conversation about the need to have a more structured template and the need for everyone to make it their business to ask some of these things when they're out visiting across the trust, not just the physical health nurses. You know, these things don't happen overnight, but and the data was by no means great, but it did come from the EPRs, and they each had BI teams that pulled it. And for the 7 trusts that we were happy with their data, the quality was good, and it was a good sized data set. It's a shame that 2 of the trusts, the quality was just so poor, it really would have swayed results when we looked at the London picture and not told us much at all. So we had to decide to disregard it.
Another question. Was there any thought about what drugs patients were on particularly? Because there are certain drugs which are more likely to cause physical health conditions and cause kind of metabolic syndrome.
I don't know too much about that element. I know some of the drugs are included in the definition of SMI that we were following. So people on certain drugs, whether they've got a diagnosis of bipolar or schizophrenia or something, if they're on that drug, they'll be considered on the SMI register. But beyond that, I don't think it was considered, but I couldn't tell you confidently on that, I'm afraid.
Thank you.
So a quick question. So thank you very much. It's really important work. Am I to take that these 9 trusts, 2 didn't have data whereby they could be monitoring their own performance in this regard, and that the other 7 hadn't been up to that point? Or were any of the trusts you're working with able to say, oh yeah, no, we know what that number is because we keep track of it ourselves already?
I think the answer is it varied. Some trusts, have their own dashboards where they're constantly monitoring this, and that was definitely the case for, well, I probably shouldn't be naming and shaming, but that was definitely the case for SLAM, and one of the reasons why we worked with them initially, they've got really good data dashboards, and the physical health check team going down the list and seeing who's up next on a regular basis. That isn't. I think it's patchy. The 2 trusts we didn't get data for, it's not because they're not recording it. It's because something went very wrong with the way they pulled the data off, and we just didn't have time to rectify this. I don't think it's that it doesn't exist in their EPRs. It was more of a probably a business intelligence issue.
Okay.
Sorry, some of my question may have been covered already now, but I've done similar analysis, but on the flip side, I've had access to the primary care data, but not access to the mental health data. Colleagues within our programme are trying to work out how to get that information into the primary care record so that it then goes towards the 6 physical health checks 70% target. Especially now it's automatically extracted from GP records, so there's no even manual submission to be able to. So mine was the interest in how you got that through the SLAM. So I appreciate you've just explained that, but it was Was the SLAM data set up specifically for this programme, or was it already been provided as additional Schedule 6 or monitoring or part of your SLAM process anyway? So did it fall out naturally from what you were already getting, or did you have to do that wider? I think you've probably already covered that in your template, but yeah, it was just...
So we actually have access to SLAM data because we're hosted by NHS Trust that's part of a structure that means that we can access SLAM data. I won't bore you with the structural details. So we did the extraction ourselves. In terms of getting that into primary care, I'm actually working on another project at the moment to look at embedding mental health nurses in primary care to do the checks on behalf of the practices, and it is really tricky. We are they basically, once they've done the checks, have to note it all down on the spreadsheet, give it to an admin at that practice to then upload it to the system. And we had chats at the Physical Health Networks lead meeting, and I can't see that that's different across any of the whole London patch. It's all being done manually where it is being done. Otherwise, people are having 2 checks, which is crazy, and that's why the interoperability issue is massive. Yeah, I don't think there's a solution to that.
No, ours is similar. Our mental health practitioners who are embedded in primary care are still having to update the mental health net, and therefore it involves dual recording. So again, the complex. And also, just to note, your first trust that you mentioned is our entire county.
Okay, yeah.
My name's Rich Sanders from South Central and West Commissioning Support. I just wondered if you were able to look at any kind of geographic relationship, like distance travelled or anything like that, or did the aggregation fall that, or did you just think London's pretty well connected, that's not an issue?
We didn't look at that. It's an interesting one. I think ultimately the main reason we didn't look at that was because we were trying to get around IG, and that would involve getting people's postcodes. But also the trusts all work very differently. Some of them have people doing outreach to people's houses to do these checks, and sometimes it involves going in. So it's actually I think it would be quite a complex picture. Not that it couldn't be done, but it feels like a whole another piece of work. But yeah, my sense is that it might be useful to do more of a qualitative piece about the reasons why people aren't getting checks, and if journey time and distance is a factor. I think then look at that. But there's a lot that we don't know still about why people aren't coming forward. The nurses themselves actually have quite a lot of intel, and there's a lot of nervousness. Some people just don't want health interventions. There's they're wide-ranging reasons. This is a really, really difficult group to engage. But yeah, I think that would be an interesting angle if that fell out as a reason, for sure.
Thank you.